Looks like we are live. Well, welcome. Welcome, everybody. So nice to see so many familiar names out there. Really appreciate you joining us this afternoon. Before we get started, just a couple of things in terms of process. You can see the chat that's available. If you want to submit questions at any point, please go ahead. We probably won't address questions till the end, but we do want to receive any questions that folks have. Also, following the meeting, you will get an email that contains a link to this recording. So if you're not able to stay for all of it, or if you've registered and you're not out there hearing me talk live, maybe you'll be watching me in a day or in a week. We expect to go 40, 45 minutes today, depending on how many questions we get, but we're really looking forward to talking today about in-home assessments, the great value that's driven by actually being in a member's home as opposed to seeing them in a clinic, and about how we've seen them evolve and how we think they're going to evolve going forward. I was first exposed to in-home assessments when I joined Inovalon, which is CCS's former parent company, back in 2012. And I was immediately taken under the collective wing of a couple of wonderful physicians that became mentors, Dr. Kate Eshelman, Dr. Paige Killian. They were adamant that in-home assessment should be about much more than simple code capture and risk revenue. And perhaps they were a little bit skeptical of the new empty suit that had been brought in to build this business for Inovalon. Fortunately, their vision really resonated easily with me. I have a public health background, and I was excited for the opportunity. What I saw in the ensuing nearly 15 years was not at all what I expected to see after training with them for a few weeks and months. It was much different than expected. But it's been a great ride, and I'm really excited today to share with you the perspectives of a couple of really deep experts in the whole IHA space. I want to start first with our Chief Medical Officer, Dr. Joe Jasser. Please introduce yourself.
Thanks, Jim. Joe Jasser, internist by trade. I've been a healthcare executive for 20 plus years. Majority of my time has been in the Medicare Advantage space and running the care delivery organizations for large hospital systems, as well as Humana's care delivery system in South Florida. I've lived and breathed in-home assessments for most of my career, Jim, and thanks for the opportunity to be here. And I'll turn it over to Jessica Ganchrow, our lead clinician. Jess, you want to introduce yourself?
Absolutely. Good afternoon, everyone. I'm Jessica Ganchrow. I'm a physician assistant. I've been a physician assistant for the past 20 years, which is an interesting thing for me to say. I just hit that landmark. I've been with ComplexCare Solutions with the company actually before it was purchased by Inovalon back in 2012. So a lot of my career has been in this business as well. I actually still see patients in the emergency department today on some Sundays when I don't want to spend time with my family. And I'm just really excited to be here and to really talk through how our in-home assessments can drive better insights. It's a really important thing that we do.
Jess, thank you so much. So I think we're going to start today talking about some of our topics, of course. So we're going to start with the evolution of the in-home assessment from the early days of the early teens. We really want to spend some time in focusing on some of the valuable information that's captured in homes that isn't fully taken advantage of today. I really want to spend some time on thinking about not just the pressures that health plans are under today, but the opportunities that we're seeing from this evolution of in-home assessments. It's not all bad news. I think there's a lot of good news and a lot of new opportunities for health plans, even though we're not living in the same world we were 10 years ago. And as I mentioned earlier, we'll have a Q&A at the end. So please send your questions in at your convenience, and we'll get to them when we're done with our prepared remarks. So as I mentioned earlier, I started with in-home assessments under the tutelage of a couple of wonderful physicians. And when I went out into the market to begin discussing our vision for in-home assessments and how we think they should be formulated, I was struck that our vision was not generally accepted by many health plans. Not all. There were definitely some progressive health plans that right from the start saw the vision of a more holistic IHA. But I would say for the most part, the response I received was that this is much more of a revenue stream than it is a care path. There was certainly a drift in the ensuing years. Slowly, there was a movement towards bringing risk and quality together, doing a bit more year over year in homes, but it was largely driven by risk revenue for many years. But in the last 2 or 3 years, probably driven by, version 28 changes, the continued bellicosity of the OIG, much for the good in most cases, and of course the ramped up auditing processes. That has driven a lot of change, and I would say that the dominant reaction we get from health plans today is, what more can we do in our IHAs? How can we drive more value in our IHAs? It's about so much more than risk revenue, and that's been a refreshing change. Joe, I want to start with you. I'd love to hear your response. Does what I have observed resonate? Have you seen different things, more things?
No, Jim, I think you said it right. When you look at it, CMS is shifting Medicare risk or Medicare Advantage risk adjustment away from the one-time diagnosis capture, as you noted, and towards a clinically meaningful, more treatment-linked documentation process. And as you noted with the Vision 28 model, every condition nowadays needs to be clearly validated, but more importantly, connected to an active care plan and supported by strong follow-up. It's increasing the scrutiny on in-home assessments, and it's, as you noted about the audit risk, with elevated audit risk, there's greater emphasis on the quality, the documentation, compliance, and more importantly, in my view as a physician, is the patient value. When you take a step back and look at, the vendors performing the in-home assessments need to evolve with the model. The assessments should really drive more of the preventive care, the med reconciliation components, social determinants of health, screenings, and then closing the loop on occasion when possible. And then more and most importantly, seamless communication back to the PCP. As you noted, the days of volume-driven risk coding are over, and CMS now expects the in-home visits to function as an integral part of the value-based care spectrum. The vendors in the space can demonstrate compliance, clinical rigor, and really impact care coordination in a more meaningful way as this continues to evolve over the next several years.
The evolution brings me great pleasure. It's clearly the right thing for the patient, and at the end of the day, it's the right thing for the industry. I'm excited by it.
I agree with that. 1,000% agree.
Jess, we'd love to turn to you. Happy to hear your thoughts here on the evolution, or if you want to jump right into what's going on in the home, I'll turn it to you.
Absolutely, I'll do a little bit of both. I am excited about the evolution of where we were, where we are today, and where we're going. Again, doing risk adjustment visits myself from the very early on, it was a coding encounter, and now this is a real clinical encounter, a holistic picture. And once we get to the point where we're providing real longitudinal care, I'm really excited because, again, as a provider, as a physician assistant myself, I think about the patient first. So it's really exciting for me to see how we can make a big impact on the patient, assisting the PCPs and the health plans along the way because of that care that we're providing the patient. So let's go ahead and get over to the next slide and talk a bit more. So what we see behind the door. We get to the door, we knock, right? And then what we're seeing they open, right? The doors open, the entire picture changes. What we see in the clinic in a patient is very different from the patients in the environment that we're seeing at home. There's a lot of hidden barriers that can drive outcomes, right? We don't see this in claims. We don't necessarily see this in the EMR when we're not in the home setting. So the home is revealing the truth. What you see on the screen here are a lot of the things that we are seeing in terms of barriers to care that are affecting those longitudinal outcomes that a PCP doesn't necessarily know. A PCP doesn't know that there are empty cabinets and that this person doesn't have good food to eat, right? They don't know necessarily that they can't afford their medications, because patients often are stretching out their medication dosages. So they're just going and saying, yeah, I'm taking my medication, not being honest about it. Moving forward, I have two patients here that I'd like you guys to meet. So let's go ahead and move on to the next slide. And let's meet Randall. So Randall is a 68-year-old male. He lives alone in his home. And you can go ahead and read the stuff on the slide here. I'm going to go ahead and just talk about Randall a bit. Our provider.
Hey, Jess,
yeah.
Jess, if I may ask, is this something that you made up and you wrote, or is this actually somebody that one of your NPs saw in the home?
So this is a real case. One of our nurse practitioners had, and the name has been changed for PHI purposes, but this is a real case of a real member that we saw in the home setting. And we monitor these types of things. Our providers will send over CMRs, and this is how we get this information and this data. We'll talk more about CMRs later. So Randall is real. First thing that happens is this is a visit that took place in August. The provider arrives at the member's home and is kind of hit in the face with the heat in the home. There's no air conditioning, and it's very dark in the home as well. So the provider made a comment, "Oh, it's really hot in here. Do you have an air conditioner?" And the first thing Randall says is, "Well, I do, but I don't turn it on because the electric bill is really high." And Randall can't necessarily afford his electric bill along with his medication as well. So he's making a choice to kind of sit in a little bit of discomfort and get his medications instead of being comfortable and cool at home. He has diabetes, hypertension, hyperlipidemia. When we go into our assessment, we ask things, the SDOH questions, right? We ask about food security. He tells us, "Oh, no, he's fine. He eats pasta every day. He gets a good sale at Pathmark for, 69 cents a box. And so he's eating that every day." And he's really happy about that, because that also allows him to afford a bit more of his medication that he couldn't afford otherwise. When going through the medication reconciliation with this member, we see that some of the bottles are kind of partially used, not really aligning with the dates that they were filled, because he's rationing his medications. He's rationing his insulin. He has to make a choice every day, eat or meds, right? Be comfortable or medication. Again, he lives alone. He has very little support at home. He used to have a neighbor that helped him, but that neighbor has since moved away. The neighbor was helping him with transportation to his PCP visits. The neighbor was helping bring food over once in a while, but that person is gone, which has also now led to him feeling isolated and depressed. So a lot of these things are things that we're seeing in the home environment that a PCP won't ordinarily see. We spend an hour of our time with the member and really get to know them and understand them, right? So on the flip end of this, what is a PCP seeing? They're seeing that Randall didn't show up to his doctor's visit. They're not seeing that Randall couldn't go to his doctor's visit because he didn't have a car ride there and he couldn't afford the Uber or taxi to take him there. They don't know that he's not taking his medication. It's really valuable what our providers are able to do in the home, not only from the time that they're able to spend, but just the eyes and the feet being in that setting that are often not seen. So I'm gonna pause for a second, and I was supposed to do this later in terms of the tee up guys, but I'm gonna ask Dr. Jasser, in your environment, right? What do you think about a Randall?
You're answering a lot of the questions we don't know, Jess. And it's like we sit back and they're non-compliant with their medications. They're not filling them. They're not getting to their office visits. They're rescheduled, constantly rescheduling. They're not showing up. We have no clue as primary care physicians what's going on in the home. We assume once we write a prescription, they fill it. We don't understand that they have to put food on their table or buy their medication or ration the medication because of all the components you brought forth. We have no idea that they don't have the funds to be able to keep their AC on and kind of living through all of that. Bringing that information back into the primary care world really helps us with our decision making, in that how do we help the patient more effectively, and as a clinician help them kind of meet them where they need us to meet them, which is understanding that they can't fill their prescriptions on a regular basis. So what are the other options here? How can we get more education? How can we help them in different ways? So what you're seeing in the home and what we see in the home is so much different than what the perspective is at the clinic. No doubt about it.
Yeah. What we were able to do with this member is that we initiated it today, right? And we want to do even more for Randall. But today, what we're able to do is we were able to initiate a case management referral so that we can tap into that health plan supplemental member benefits, right? There are perhaps things there that Randall doesn't know that he's eligible for. And obviously, it's the goal of the health plan to keep Randall happy and healthy at home, avoid a costly hospital admission, make sure he's getting his medication, and see how they could support him. So again, just what you said, Dr. Jasser, just being those eyes and ears in the home and just bringing to light, both for the PCP and the health plan, that these are real issues that we could impact that will benefit everyone, Randall, PCP, and the health plan. So let's go ahead and meet Maria now. Perfect. So Maria is a Spanish-speaking patient, and we were thankfully able to send, and she's, before you ask Jim, she is real. So I'll head you off there. She's real. We were able to thankfully send over a Spanish-speaking provider to this member's home, which is such a huge benefit when we could speak to a member in their language, right? Obviously, there are translation services that we use and we have to use when needed, but there is something really special about being able to speak with someone in their native tongue. It almost forms a bond in a community right off the bat. What this provider saw when they arrived is, first of all, 28, you can see on the screen here, medication bottles. That is overwhelming to see. And what we found when we dug a little bit deeper is that there were a lot of duplicate medications or medications that are the same family, medications that were filled by different pharmacies on different dates, and medications that weren't being used because she was also kind of rationing her medications. So she had bottles that had been filled that weren't used, bottles that were, partially used, and so on. Multiple prescribers. What else? What we also saw in this home was that there were a lot of fall risks, right? She was a little bit of a hoarder, Maria, which we see often in the home setting. She had a lot of carpet on the floor with upturned carpet corners, just those little things that you can't see in the doctors from the PCP's office are things that we're able to identify. Turns out Maria has osteoporosis. So that little upturned carpet corner can result in a fall that could result in a broken hip, which we know that we can all appreciate the morbidity and mortality of someone after having a broken hip is really poor. So again, these are just these invaluable things that by having that set of eyes there. What did we do for her? We helped her clean out her medications. We helped her identify what she should be taking today versus what she should discard. We spoke to her about, how to discard medication properly. We also noted in the home that there were a lot of food wrappers and things that were not the healthiest of foods to be eating. So we spoke about how these foods, what she could look at on a food container in terms of sodium in food to avoid high sodium foods. We were able to give her, speak to her in her language and really share some good insights with her and help reduce some of the barriers in terms of education and health inequity with this member.
Jess, one of the things you said was really important, which is the education aspect of things. When looking at it from the PCP's lens, our main focus is seeing the patient in the office, getting the medications adjusted, getting the physical examination completed, and then we move on to the next patient. Having that time to spend with them in a meaningful way to educate them about their diet, educate them about their nutrition, educate them about the medications in a way that you're meeting them where they are is much more impactful than what we're able to do in the PCP's office. The med reconciliation component you just brought up, answers a lot of questions from a doc's mind. Why do they have, Coumadin that's been sitting around on that's 5 milligrams when I told them to take 2.5? We don't appreciate the complexity that we introduce into the patient's lives by mixing all the medications and a number of medications they have to take. So, from a physician's perspective, that education, that moment of spending the time with them to explain is really impactful.
Yeah, absolutely. So for this patient, again, we were able to initiate a case management referral, tap into her health plan supplemental benefits, get her someone to work with her in terms of managing her medication. A lot of health plans could offer these types of benefits to their members that they just don't know about. We can move on to the next slide. So these are not just stories, right? These are real people, like we said earlier. These are real people. These are someone's parents, brother, sister, mother, father. And we spoke about two cases specifically, Randall and Maria, but these are issues that happen at scale. We could see that 41% of our referrals are referring from social or community needs, many of them unsafe environments or fall risks in the home, new diagnoses that the member doesn't have awareness of how they should be managing this diagnosis to prevent a hospitalization. Depression, that's a huge issue, especially in our older population. We see the trends in behavioral health and where that's going today. Non-adherence to treatments, maybe not because they don't want to, but because they can't. They're making decisions again between food versus medication. Transportation assistance, inability to afford medications. In 2025, we submitted over 21,000 case management referrals to our health plan partners. And again, 41 for social and community issues that we really can make a huge impact on. So just, to kind of hone it in from my perspective, these risk adjustment visits are not just coding encounters. This is a real way that our provider, in the hour plus time that they're spending with the member, can really take a holistic approach with the member and really tap into all of the different areas aside from what diagnosis does this member have, right? We take that time, we make a huge impact in that hour. We're talking about behavioral health, medication adherence, gaps in care, tests that they need to have done, right, to help close quality gaps, like the retinal screening exam that we can do in their home at the point of care, A1C testing, things that are really helping us, again, with that longitudinal outcomes that we're looking to impact and to just have a benefit on. So each of these visits is going to help close these gaps in care, help support the member's ongoing care plan, initiate referrals to their PCPs and specialists. And just, I have to tell you, just from a personal perspective, it's just so rewarding to be able to be in the home and do these visits and spend the time, because to your point, Dr. Jasser, at the PCP's office, you just don't have the time. You have to go to the next patient. Even in the emergency department, they're coming in for an acute event. We're very limited on what we can do. So these home visits really do matter.
No, I agree with that 1,000%, Jess. And when you take a look at the market as a whole, as I said earlier, it's shifting. It's shifting on more of the focus of longitudinal care. What are the things that we can do in the home more meaningfully than just the risk adjustment components of it? Being somebody who brings forward the supplemental benefit information to the patient in their home to identify food insecurity, transportation insecurity, as you were mentioning, is going to be really critical. Moving into a space where we are more longitudinally engaged with the patient, whether it be during transitions or connecting with the care teams and those types of things. So, I think we're at a very critical inflection point in the evolution of Medicare Advantage with the changes that we've seen, and especially with the version 28 components coming down, that the focus on longitudinal care and engagement with the patient needs to shift with the market and what the expectations are. Jim, I don't know from the plan perspective if you're hearing anything or seeing anything, but as a clinician, from my perspective, it seems to be screaming at us in the face. So
it really is such a positive evolution, and this calls to mind a good colleague that I've worked with at a health plan for 10 years, and he's in the finance group. 10 years ago, really all he wanted to know was, what's my ROI? How am I doing? 2 or 3 years ago, he started to really talk more about, are we getting quality gaps closed? How are we doing? Are you getting CMRs into my care management group? And it reminds me, 10 years ago, the follow-up that was gold standard was submit a CMR and mail a SOAP note. And that was gold standard. That was good stuff. It's not enough today.
Hey, Jim, what's a CMR? What's a CMR though? I mean, I'm a little slow to the game. So,
well, thank you, Dr. Jasser. I'll explain this to you because it's very complicated for someone with little education. It's a case management referral. And of course, every health plan has a case management team that works with members with complex needs And one of the common outputs from our IHAs is a case management referral, sometimes urgent, sometimes non-urgent, that will go over and be picked up by typically a team of nurses, a team of social workers, and they will connect with the member and try and connect them with the right resources, be they community resources, additional medical or behavioral resources. But that historically, that was sort of the best an IHA could hope for, was to send a CMR and send a SOAP note to the PCP and feel very good that we had done all that we could. But most recently, Rich hasn't just been asking about my ROI or if quality gaps are being closed. He actually said to me this summer, he said, your CMRs create such a huge workload for my team, and you're really just telling me what I need to do. Can you tell me what you're going to do for my members rather than just telling me to do it? And that just totally flashed a light bulb in my head where I realized health plans, even when they're working hard to do their absolute best, they need more help. And rather than just an in-home partner being one more transition where things might get dropped, they're pushing us to hold that ball and carry it forward ourselves rather than just hand it to somebody else and ask them to do the next phase of work. So that was the most recent and one of the most meaningful evolutions in a particular executive that I've seen in the last many years.
That's interesting. And when you look at it from a clinician's perspective, from a PCP, those extra touch points in the home are actually quite meaningful. We were talking, Jess, and the ability for in-home assessments to take a different role than just code capture or HCC chase, as the industry is kind of as the vendors have been looked at, is going to be very compelling and very meaningful. A lot of the patients that we see in the home are those that can't make it to the office on a regular basis. Getting the care to them and getting the services to them where we can be most impactful is going to change a lot of things. So I echo the concern and I echo the excitement around the move in the market, and kudos to your friend Rich for bringing us to task on it.
Beautiful. So I'd love to think a little more about what is next. I mean, we've talked broadly about what is next. What are some of the specific elements, maybe some of the policy elements that are driving, not the change we've seen up to today, but what are the signals we're seeing from CMS and other places about changes that we need to be mindful might be coming over the horizon?
Jim, that's a great question, and we're watching it happen as things are moving, and they're moving very quickly. We've got the team model that's coming up here in 2026, CMMI releasing that one. Once again, looking at bundles, looking at value-based care. How do we manage patients across a continuum from the hospital acute setting, post-procedural into the post-acute setting, and preventing the readmission and limiting bad outcomes. We're also just saw it this past week with access. And how do we take technology to be able to provide scalable solutions to patients for more longitudinal care of chronic conditions? These are two big moves by the administration, demonstrating the view that I think is going to continue to evolve over the next several years to emphasize longitudinal care of chronic conditions, looking at the outcomes, looking at the way that we drive value to the patient, as opposed to just how do we create revenue for the system. So I think it's going to be exciting. And now that technology is moving very fast, is how do we implement the technology? How do we leverage what AI and machine learning and all these new technologies can do for us? So it's going to be a rapidly moving field, but all the cards are indicating that it's going to be more on the value outcomes, longitudinal, and focused around the patient and the care the patient's receiving.
It's so exciting to think of our work as being part of a care path, part of the care continuum, and not just a one-off. I kind of feel like it's turning into the job I accepted 15 years ago, and it's exciting.
Yeah, it's taken 20 years for the whole world to change, and it is very exciting, Jim. It's great.
Well,
You want to,
Joe, any last thoughts before we see if we have some questions?
no, I was going to say questions, Jess.
Nothing to add except my overwhelming excitement about the process and where we're going. I really am. I mean, using the technology and AI, understanding how a risk adjustment visit really is going to help with improved resource allocation, improved outcomes is really it's an exciting place to be. I'm excited to be a part of it. And yeah, I'm ready for questions.
So I see a first one here. It reads, I like your vision for IHAs evolving to more fully supporting patients seen in home. What are the barriers to doing that today?
Jim, I
Jess,
think,
Joe, do either of you want to pick
yeah,
that up?
I'll pass it over to Jess here in a second. And one of the things I think that we're dealing with is the information sharing, communications across from the plan to the provider, and then back and forth. As Jess was noting earlier regarding the supplemental benefits, understanding the supplemental benefits, there's such complexity around it. What can we provide the patient at the point of care? Getting that more seamless, creating more seamless information sharing around that, and then ensuring that the primary care physician is engaged in a lot of the interactions in the home, letting them appreciate that there are food insecurity challenges, or there's rationing, those types of things. When I look back at it, this is where technology, why I'm so excited about it, is really going to help us, is facilitating the information sharing and connecting a lot of the points that we're not able to connect right now. Jess, I don't know what you're seeing, or if there's anything to add.
I think what you said initially, Dr. Josh, is kind of information sharing between the health plan and us, right? I think just having the correct data so that we could target the members, reach out to the members, is a really important first step, right? If we don't have the correct phone number information, we just can't reach them. Getting the members to answer the phone. Obviously, with an older population, there could be some hesitancy to allow a new person into the home. So what our goal is to really socialize our types of programs so that there's no hesitancy. This is a normal part of their healthcare continuum, right? This happens. And this is just another benefit to them. And overwhelmingly, what we see is that members that we've visited 1 year will absolutely answer the phone and welcome a visit the following year, because they're so happy with the service and the time and the education that we're able to provide to them. So it's just getting that first foot into the door, and that could be a challenge with data.
Thanks, Jess. Joe? I've got another question here. It reads, my experience with IHA providers is that they have narrow tool sets and processes that are designed and optimized for what they've historically done, risk adjustment visits. Are there tool sets on the market that are ready to take on these challenges today?
Oh, great question. Jess, I'm going to put you on the spot for this one first, because being the one who does them, you've got a much better perspective, and I can kind of put pie in the sky.
Yeah. I'm a little biased with our providers, and we give them tons of tools to do a head-to-toe physical exam. So I'm going to go ahead and I'll answer the question by saying kind of our methodology in the home, right? So a visit is scheduled, and our provider goes out to the visit. They do a confirmation call, and they really do a head-to-toe history review of systems and then physical assessment. There are some limitations, right? Where we're not doing things like breast and prostate exams in the home setting today. That's not something that we're going to be doing. But we certainly equip them with all of the things that they need to do a good, accurate assessment, right? When we're talking about things like looking for diabetic neuropathy, right? Our providers have tuning forks, they have monofilament tests and things that we could do to assess neuropathy in the home. Where in terms of points of care testing, this is a new place that folks are going to. We're doing retinal images in the home. We're taking pictures of their retina so that we could go ahead and upload them to an ophthalmologist and have that test done right from the comfort of their home without requiring dilation even. We're doing A1C testing in the home, KED quality gaps, leaving fit kits with the members. So although there are certain limitations, we are absolutely looking to stretch our reach as much as possible to get beyond those barriers and do all the possible care that we could do in that home environment with them. Again, and with the goal ultimately to provide that holistic care, that longitudinal care, sending that information to their PCP, not duplicating efforts at all, being really concise in the care that we're giving so that we could, just again, what I've said from the beginning and what I tell patients when I used to see them in the home is our goal is to keep you happy and healthy at home. And that's really what we want to do.
Joe, maybe you can expand on that a little to share how tool sets might need to evolve to get more information into the home and develop more pathways to get expanded information back, not just to the PCP or just to the plan, but other care points within the continuum.
Yeah, no, Jim, thanks. And where I see this as kind of more of the utopic pie in the sky vision of, as we're looking at software as a medical device coming to market very rapidly, how do we leverage that technology more meaningfully by having somebody help the patient do X, Y, and Z, whether take a picture of a skin lesion or to your point, Jess, the retinal screening, things as a physician we may or may not have the capability to do in our own office. But as software and AI move very rapidly into the healthcare delivery space, leveraging that in-home to be that extra touch point to be able to do a lot of the things that we will not have the time to do in the office. I see that coming very rapidly. You look at some of the new companies that are out there regarding voice depression screening, or you look at companies that are doing mobility assessments using AI. We're not going to have the time to see 30 patients in a day in a physician's office, but an hour and a half in a patient's home to connect all these dots is going to be a lot more meaningful. And then add to that kind of the components around social determinants of health. Kind of jump into one of the questions I saw pop up is how are we going to be impactful in delivering on some of those services? Understanding what the supplemental benefits are from the plan and being able to facilitate them immediately at the point of care, leveraging the data infrastructure that we're going to be able to build here in the near future, to know that the supplemental benefit has a food service, to be able to deliver that and make it meaningful at the time of that visit. These are the things that I see as very exciting in the in-home assessment world, and where I, as a physician, want to see things going faster rather than slower.
Excellent. We've got a question here that says, how will this level of SDOH information be shared with their PCP? Currently, I believe only a small summary is typically being shared.
Yeah, as we going back to what I was saying earlier, Jim, around the communication and that sort of stuff, it's challenging to get information into physicians' EHRs. We know this, but how can we take the summary of information, share it back with the plan and with the primary care physician as we evolve, is going to be very impactful and very important to do so. I think looking at it from the lens of the primary care physician is what are the components they're going to be concerned about and things that can help the patient with. Transportation insecurity, okay, I'll work with you on those components. But for us to be able to share with the primary care physician also goes back to primary care physician to say, I'm willing to accept that information and incorporate it into my practice. It's a two-pronged approach. A lot of the docs that are out there see in home assessments is, you're just going in there to do risk capture. That has to evolve into what we've been talking about here for the last half hour, 45 minutes around we're doing more in the home. We're doing things that you don't have the time to do. Please accept this information as additive to what you're trying to accomplish in the office. So it's not just the information sharing, it's also the willingness to accept the information and incorporate it into their decision-making process as I see an opportunity here. Jess, I don't know if you want to add anything. I know we ask a lot of questions and we share a lot of information with the docs, but I'll tell you, as a physician, I just don't have the time to review it all.
I'd say it's a bit of a culture shift. And again, what I had mentioned earlier in terms of socializing the importance of these visits and the value that they have, I think it's going to be just a culture shift that we're going to have to say all the time to everyone, everywhere. And it should be out of everyone's lips, right? This is an important, valuable thing. This is everything that you have to offer. We do share the information with the PCPs, but to your point, they're so busy, they don't have time to read it.
Mm.
So our impact is to, again, tap into those supplemental benefits the member has, send it over to the right person so that while the PCP doesn't have the time, at least their care needs are being met with our support.
And isn't it our challenge to be sure that what we're communicating back is so valuable that they do have the time? If it takes 5 minutes to take in some information, but it saves you 10 minutes of work, then you always have the time. So I think some of the challenge is at our end. How do we provide just the information in a really easily digestible, easy to find way so that physicians do have the time because they value what they're reading?
Yeah. I also go back to what we were bringing up earlier, Jim, and that is the plan and the care managers and their ability to assist with some of the challenges that the patient is experiencing. As physicians, once we start to see some of that value be delivered to the patient, our perspective will slowly change. Understanding that the in-home assessment highlighted it, the case manager at the plan was able to help along the way. And when the patient comes into the office, says, "Oh, thanks, thanks for asking about X, Y, and Z," or the plan was, my health plan was able to help me with A, B, and C. These are going to be impactful points of for the docs, and to your point, Jess, is going to start changing the conversation around how in-home assessments are perceived in the marketplace.
And just the information that we send over is just so valuable that it also helps really with resource allocation, both at the PCP's office and the health plan, right? So we're doing a full assessment that we know that a care manager needs to know the kind of level of risk that that member has. We're able to do that initial survey and send it over. Hey, this is a high risk patient. This is where your resources should be allocated, as opposed to this person who's perhaps more low risk. We could stratify our time a bit easier, so that we're doing the right thing at the right time for the members that need it the most.
I've got one more question, and this actually came to my phone. And it's from Jim. And it says, "Jim, I'm on my phone and can't see the chat. Question, can you expand on the opportunity the new CMS access model presents for plans and providers?"
Oh, that's a loaded question. I'll answer it at a very high level because I don't think we know the details of access just yet and how it's going to impact the market. But what it says to me is that they're opening their eyes. They're willing to accept these new technologies, whether it be RPM or any of the devices in the home, as part of the care process, and the ability to leverage technology meaningfully and be reimbursed for utilizing that technology is going to change the way people practice. When my first read of the overall CMMI's press release around this was, we acknowledge that there's technology is changing the way we care for patients. We acknowledge that care is being delivered in different sites outside the hospital, outside the physician's office, and leveraging technology to do so. We want to incentivize it so that way companies will build their process more effectively and efficiently to meet the needs of the patient, allow for scalability so that we can deploy it broader. So
I agree. And I think as with, most everything that comes out of the Innovation Center on day one or even year one, it's really more of a signal than anything else, because how the market's going to respond and what unanticipated consequences are going to grow out of it and how they're going to amend the program is always unknown today. But clearly it's a strong signal towards recognizing the new and in some ways not yet even understood role that technology is going to play in our healthcare next year and 5 years and 10 years. And it's great that the Innovation Center is moving there.
yeah, I agree.
So I don't have any more questions. Any last thoughts that either of you would like to share?
No, thank you everybody for your time. It's been a great conversation, Jim. I really appreciate the opportunity.
Thank you, Jess.
Absolutely. Thank you guys, and have a happy holiday season, everyone.
Thank you, Jess. Thank you, Joe. And thanks to all of you that spent a few minutes with us today. We appreciate your time. do be on the lookout for an email that will have this information, have a recording in it for you. And please be in touch. Our contact information will be with it. Please be in touch if you have follow-up questions or if we can be helpful in any way. Have a great afternoon, everybody.
Thanks,
Take good
Jim.
care.